welcome to the final day of the summit. Today's theme is collaborations to amplify access and equity. We're excited to discuss hepatitis B outreach in non-traditional settings, including community pharmacies and harm reduction. And we're going to reconvene with Dr. Bernie Lopez and Chioma Nnaji for a reflective and interactive part 2 of bias and racism and health disparities. At the end of today, we'll see you at the awards reception to celebrate our 2020 Hep B federal and community champions. And now a quick word from one of our sponsors.
Janssen's vision in hepatitis B is to find effective treatments, and we firmly believe this will be combinations of drugs that will be required that will bring about high levels of functional cure. Hepatitis B is a disease with enormous global impact. There are nearly 300 million people who are infected with the virus today. Of the fewer than 20% who actually know they have the disease, only about 5% of the total number actually get treated. Patients with hepatitis B, if they're untreated or fail to respond to treatment, will face health issues in their future. The two most concerning are cirrhosis and hepatocellular carcinoma, which can lead to early death or the need for a liver transplant. It is a serious health issue. The current standard of care for preventing hepatitis B is adequate. There's very good vaccines. However, the current standard of care for treating chronic hepatitis B is woefully insufficient. The treatments require lifelong treatment. Somewhere between 5 and 10% of people will actually undergo control of their disease. In order to achieve high levels of functional cure, there are two things that must happen together. And so we see any treatment we develop as having these two main pillars. The first is that you need to be able to control the virus replication. Then the second pillar is to teach the immune system on how to make the right types of immune cells that will then control it lifelong. This is a very exciting time to be in hepatitis B research, and in particular, very exciting to be at Janssen because we have one of the deepest and broadest portfolios addressing multiple different mechanisms of action, each of which could contribute something towards a cure, especially when they're used in combination. In addition to our R&D activities, Janssen is very involved with supporting the hepatitis B patient community. In particular, we are very concerned about helping the patients deal with the stigma that it goes along with being infected by hepatitis B. Hepatitis B has always been near and dear to my heart. It's a disease that I find very interesting and I'm very passionate about.
Hello, everyone, and welcome to Session 8, Expanding Hepatitis B Outreach in Non-Traditional Settings. My name is Daniel Ventricelli, and I'm very excited to join all of you for the Hep B United 2020 Virtual Summit and to serve as the moderator for this session. As a little background, I'm an assistant professor of clinical pharmacy with the Philadelphia College of Pharmacy at University of the Sciences, and my research is largely focused on addressing barriers to accessing medications for opioid use disorder in the community setting. And I've had the opportunity to collaborate on a handful of public health efforts aimed at improving access to services for patients with viral hepatitis. Today, we will be discussing innovative strategies for expanding access to hepatitis B vaccinations and screening in unique settings like community pharmacies and within substance use disorder treatment and harm reduction settings. I'd like to start by introducing our first speakers, Jeff and Alyssa. Dr. Jeff Bratberg studies community pharmacist roles regarding opioid safety, opioid overdose, harm reduction, and opioid use disorders. He is a consultant and co-investigator on 2 federal grants, a randomized controlled trial of pharmacist use of collaborative practice agreements to manage medications for opioid use disorder, and a multi-state randomized control trial testing the effectiveness of a pharmacist and pharmacy-focused intervention to improve naloxone provision, non-prescription syringe access, and buprenorphine dispensing in community pharmacies. He was a co-investigator on a grant-funded pilot project promoting hepatitis vaccines in community pharmacies and a grant supporting research of an integrated model of HCV and opioid use disorder treatment facilitated by a pharmacist within an opioid treatment program. He is joined by Alyssa Fellini, a student in the University of Rhode Island Doctor of Pharmacy program with an expected graduation date of May 2021. She is passionate about viral hepatitis elimination efforts, substance use disorders, and social determinants of health impacting vulnerable populations. She has been a student liaison for Rhode Island Defeats Hep C to help coordinate the public education component of the 2019 C is for Cure Water Fire event and to bring URI College of Pharmacy students into the event. She is currently working to increase hepatitis C surveillance efforts as a data consultant on a CDC grant at the Kodak Clinic in Providence, Rhode Island. She has also developed, through a Rhode Island Pharmacist Foundation grant, a harm reduction pilot program to promote hepatitis A and B vaccination services in community pharmacies. Upon graduation, Alyssa hopes to continue her education in public health through postgraduate residency training.
I'm Jeff Bratberg. I'm a clinical professor at the University of Rhode Island, and I'm here presenting Promoting Hepatitis A and B Vaccines in Community Pharmacies in Rhode Island with Alyssa Fellini, who is a PharmD candidate this academic year. So we're going to talk about the background of our study, the role of community pharmacists and pharmacies, our intervention, our preliminary data, what's happening as our follow-up, and what the future implications are. So we designed the study based on the CDC Division of Viral Hepatitis Strategic Plan, which has two main bullets that we wanted pharmacy to be a part of: increasing Hep A and B vaccination coverage among at-risk adults in high-impact settings, which we'll explain is pharmacies, particularly community pharmacies, and to increase utilization of prevention services, such as vaccination, Hep B and Hep C prevention services, among people who inject drugs, who frequent pharmacies to get non-prescription sterile syringes. So what are some of the roles of pharmacies and pharmacists in public health? We feel that they're some of the most visible health professionals, and there's two sort of overlapping but distinct ways that they do this. Instead of just dispensing medications, they actually offer a huge public health benefit. So most people know pharmacies as a place to get immunizations in all 50 states, but pharmacies also and pharmacists also manage opioids and antibiotics to benefit individuals and the public. They do manage disease states and manage medication therapies, condensing them, deprescribing, optimizing therapies, using meds that work. They're a venue to link patients and customers to specialist care. They provide community education. They are integral into emergency preparedness, mitigation, response, and recovery, all of the cycle there. And they can even offer reproductive health services independently, prescribing oral contraceptives in several states. In terms of harm reduction, we feel the most important, of course, is hepatitis A and B immunizations. But for people who are at risk and people who inject drugs, all pharmacies can dispense Narcan or naloxone independently. They can deal with smoking cessation and promote nicotine replacement products. We talked about non-prescription sterile syringe sales, syringe disposal, harm reduction in the form of fentanyl test strips to use drugs more safely. For hepatitis C or hepatitis, and for HIV, they can do treatment as prevention, do point of care testing. And of course, medications for opioid use disorder, as people with opioid use disorder are a high risk, high impact group, to provide prevention services related to hepatitis. So just to review, why community pharmacies for this intervention? Community pharmacists are recognized as immunizers, providing hundreds or really millions of immunizations each year. In the current COVID pandemic, they're recognized to provide vaccinations, catch-up vaccinations down to people as old as 3. So that's everywhere now. Pharmacy staff can do this now. Pharmacy interns can do this. So really integral in our current emergency preparedness, but they've always been there and they're recognized as that. Community pharmacies deliver all those harm reduction interventions to high-risk populations, again, such as sterile syringes, fentanyl test strips, things like that. And they're equitably located. We know that people at risk of HIV and hepatitis B and hepatitis A are in areas where there may not be accessible healthcare deserts. Well, in those healthcare deserts, there's probably a community pharmacy, and so we need to continue to focus on providing that care. So when we look at hepatitis B, the most recent data is that basically everywhere except New York State, there's 67,000 community pharmacies located 90% of them located within 5 miles of every American. But there's still some barriers, not just legal. Only a third of pharmacists in a recent study assess for the need for Hep B, and only half of them stock and actually recommend Hep B vaccines. So why Rhode Island for the intervention to try to link those essential services to increasing Hep B vaccination by pharmacists? Well, in Rhode Island, we have strong relationships between the headquarters of CVS Pharmacy, our university where Alyssa is a student and I'm a professor at the University of Rhode Island. I'm a former president of the Rhode Island Pharmacists Association. Our study is actually initially funded from the Rhode Island Pharmacy Foundation associated with our IPA, and I also have a practice site at the Department of Health, where we only have one Department of Health. Our state has a universal vaccine purchase and distribution system that enrolls all state providers, including community pharmacists. And RIDO actually has an integration, the Department of Health integrates Hep A and B vaccines to uninsured and underinsured people at opioid treatment programs. So we wanted to target 3 particular groups that go to pharmacies in terms of increasing the number of patients who are, we've been increasing in the state the number of people actively receiving buprenorphine, which is a drug to treat opioid use disorder. And there's about 5,000 people, but they picked it up at pharmacies. Pharmacies also are a venue for treatment as prevention or prophylaxis, I should say, for HIV. People who have, who receive pre-exposure prophylaxis. So that is another group. They get that at pharmacies. And then focusing on populations that buy sterile syringes at pharmacies. And so this is from a study that I was involved in promoting naloxone for people who buy syringes, but obviously a group that is that may not know that they're at risk for hepatitis B. I'll pass it over to Alyssa.
Thank you, Dr. Bretberg. So now I'm going to talk about our intervention itself and the project that we did. So the postcard is what we chose to include as our medium for getting information out to the public. And so we wanted it to be something that was simple, something that was going to be easy to read for a broad group of patients, a broad group of a population. We wanted something that was going to be bold and different, something that you would notice. And so we had the postcards placed into the prescription bags or the bags when you purchased over-the-counter sterile syringes. And then we also had both English and Spanish on the same card. And so what you're seeing right here in these photos is front and back. And then we wanted something that was also going to be a passive intervention, something that was going to easily be incorporated into pharmacy workflow. As we know, community pharmacies have stayed open throughout the pandemic and have an extremely high workload. So we wanted something that was going to be an easy ask, as well as something, we know vaccine hesitancy is actually a threat to global health, recognized by the World Health Organization. And we wanted something that was going to allow individuals to make their own informed decision on vaccinating. And so you can see the QR code in the bottom right corner. And so what we linked to this card was actually a website. And so on the next slide, we go over the website that we created was hepatitisvaccines.org. And then we also have a mirror website in Spanish. And this just helped to provide more information than we could cram onto the postcard, so not to overwhelm people. And so we wanted individuals to be able to assess their own risk by going to a website on the CDC and understanding, why this is being recommended to them instead of just the recommendation thrown at them. And so we also created a map that was linked on this website to all of the participating pharmacies. We had 20 CVS stores that were involved and 7 independent pharmacies. Actually, all of the independent pharmacies in Rhode Island that offer vaccination services did participate. So we were very excited to see that. And so that just helped to assist individuals to know where pharmacy staff had the vaccines in stock and were going to be able to give them if they were to call. And so on the next slide, we put together some of the information that we got from CVS regarding the vaccines that were administered. And so through July to September in 2019 and 2020 is what we looked at. And so you can see for hepatitis A, in 2019, there were a total of 2 vaccines for Hep A provided. And in 2020, we didn't see any. However, for hepatitis B, we saw a 2 vaccine bump, which was actually very interesting because we also know that during the time of COVID, people have not been as readily going out to get wellness checks and staying up to date with their vaccines. And so taking those two, we're seeing that as a win because we've maintained and even gone above where we were last year when we didn't have the pandemic and other health concerns. And overall, we saw 8 stores increase in the amount of vaccines that were administered. 1 stayed the same and 8 actually decreased. So we had that split right in the middle. And so this slide talks about the independent data that we received. And so we each store was I just provided a number to match up. And so in some of the stores, in about half, we saw that there was none last year and none this year administered. So staying steady. But we did actually see a bump in 2 stores. And that was pretty significant for us. We know we got a lot of different feedback from each store, and they said, some said they didn't have time. Others said that they really tried to push this and speak with each patient about the hepatitis vaccines that were available. And then other stores self-identified some barriers that may have prevented them from successfully administering vaccines or successfully fostering interest in getting the vaccines. And those were a language barrier. Although we did include Spanish for all of our materials, sometimes there can just be a loss in translation. And then population age, some stores had more of a senior population, other stores had a younger population. And then obviously COVID-19 and the fact that this was flu vaccine season as well. People are just kind of narrow focused on the one vaccine. And but overall, taking those 2 stores and me seeing a bump and half of them staying the same, we're taking this to further go into what that might mean. And so we also wanted to do a follow-up survey just to see, the pharmacy staff attitudes regarding the intervention. And so overall, there were about 17 questions, but I wanted to just pull out these 4. And so how well did the postcard fit into your typical workflow? We wanted something that was going to be passive and easy. How effective was the postcard intervention for these groups specifically? And then how much has your practice changed regarding hepatitis vaccines? Everyone knows about the flu. I got this from one of the pharmacists. Everyone knows about the flu. They hear about it. No one knows about hepatitis. So that I wanted to know if the pharmacy itself had changed their attitudes regarding these vaccines. And then one that we, really wanted to focus on was, do you consider hepatitis vaccines as harm reduction? Like Dr. Bratberg mentioned, this is something that community pharmacies have been offering in many different ways. And so we really wanted to see if the idea had changed if these vaccines were viewed that way now. And so some things that, we wanted to just point out of things to improve and things to retain if this were to be replicated. We'd obviously want to keep that passive marketing intervention. We know pharmacies are busy. We want to keep something that's going to be easy to do. And then all of our onboarding materials and educational materials, we thought that really helped to introduce the project to all staff that were in the store. And then really keeping that focus on the patient making the decision. And some things to improve would definitely be our timing of follow-up. The COVID-19 pandemic and the flu season really did get in our way of, which was expected, of getting that follow-up. And our communication methods were a little difficult with email and phone call. These stores are busy and overworked, so that made it a little tough to get the pharmacy staff attitudes and the responses to the surveys. And then one big thing I wanted to point out was store selection. We decided to choose some stores based on their the population volume of buprenorphine prescriptions or maybe over-the-counter syringe sales. But after we've done this, we think that if this were to be replicated, selecting a store with pharmacy staff that were more on board to promote this might be more effective for getting more vaccines completed. And just want to leave you today with a quote. Hepatitis A and B are vaccine preventable diseases, yet they continue to be the most commonly reported diseases, vaccine preventable diseases. Getting vaccinated, especially if you're at high risk, provides the best protection from these diseases. And so that was really our aim, is something that is preventable, we have a solution for it. And then one thing, the harm reduction, our focus is really that harm reduction values life, choice, respect, and compassion over judgment, stigma, discrimination, and punishment. And I know the Hep B United really puts that focus on breaking down the stigma and discrimination of hepatitis B. So that's something that, we had hoped to incorporate through this intervention. And so thank you so much. And I would love to answer any questions in the live Q&A.
All right, thank you, Dr. Bratberg and Alyssa. Next, I would like to introduce Dr. Amy Jessup. Dr. Jessup has been involved in health-related research for 20 years. She began her career in biomedical research, investigating potential vaccines for viral diseases at both private research institutions and in the pharmaceutical industry, and was also involved in the research and development of diagnostic tests for emerging and existing infectious diseases. Upon completion of her Master in Public Health degree in epidemiology, Dr. Jessup assumed a position as surveillance officer in a CDC-sponsored community vaccine trial. To complete her PhD in health studies at Temple University, she examined immunization policies and practices in Pennsylvania nursing homes. She recently served as Director of Research and Education at HepTrek, the Delaware Valley Hepatitis Treatment Research and Education Center, and is currently an Associate Professor of Public Health at Western Michigan University. In addition to her professional experience, Dr. Jessup has been involved in numerous nonprofit organizations and served on the boards of directors for HepTrek, Hepatitis Association of Delaware, Hands for Life, the Philadelphia Immunization Coalition, and Prevention Point Philadelphia.
Hello, I'm Amy Jessup, and I'm the director of an organization called HepTrek, which is dedicated to reducing the impact of viral hepatitis. I'm also an associate professor at Western Michigan University. And I'm going to talk to you today about hepatitis B services in non-traditional settings. During today's presentations, you're going to hear from a couple of people talking about specific non-traditional settings, such as corrections or pharmacies. I'm going to talk a little bit more about all types of non-traditional settings. Okay, so this is me, Amy B. Jessup, and you can reach me at this email address after the session if you're interested in talking to me some more. So why are we going to talk about this today? It's because many of the population subgroups that are most likely to have an existing hepatitis B infection or be at risk for a new infection often come from backgrounds in which lead them to not engage fully with traditional healthcare systems and healthcare providers, right? So these non-traditional settings, it's where the people are. Okay? And why I think that it's important is that, when we look at looking at barriers to hepatitis B services or hepatitis services in general, the quotes here on this slide are what we often hear from healthcare providers, that the people that need hepatitis B services, they don't really care about their health. They don't have insurance, so I can't help them. They're hard to reach. They speak different languages, and I don't have support. So these are quotes directly from providers, and they indicate why we may need to have services in some non-traditional settings. Several years ago, we at HepTrek did a study, and we called it our barrier study, looking at barriers to hepatitis B services across the board, and we found many types of barriers, and barriers that were more structural in nature, and some that are social in nature and individual, and they kind of all overlap each other to really impact how likely someone is to get not just hepatitis B services in general, but appropriate hepatitis B services. Something that we find that, unlike what many of the healthcare providers said, we find that most of the people who are at risk for having existing infections or for new infections aren't really that hard to reach, right? They're just in different places than our traditional healthcare settings. And we recognize that they have a lot of interest, but some of the barriers that are prevalent in our traditional healthcare settings really get in the way, and that's literacy, and not just literacy, but health-related literacy. Problems with appointment making, it can be so difficult, even for me, with a desk job that's flexible and I have time to be on the phone and make appointments, it can be really hard to get through and make an appointment. Hourly workers, there's not only the time away from working to make appointments, but to get there and to sit there. And many people's workplace doesn't allow you to take an hour from work. It's like you take the day off or you don't, right? And so people need that hourly wage. And if you take too much time away from work, then you can lose your job altogether, right? So people are going to weigh having my job, which maybe provides the insurance that allows me to go to the doctor, or going to the doctor. And then there is some real and perceived attitudes and judgment from not so much the healthcare providers, but from the support staff around the healthcare providers, front desk staff, checkout clerks, people like that. Right? And sometimes these people also tell the folks that are impacted by hepatitis B most say they feel like they're a burden on their provider when they need extra services like language support. So also just even assessment of hepatitis B risk in primary care settings can be problematic. And so these are just some copies of intake forms, right? Where you go to a doctor's appointment, you're a new patient and you fill out these forms, and it's usually in the waiting room on a clipboard, and you're trying to fill in these little squares and circles. You don't always know why they're asking you these things. And so it's a little bit out of context. And on the top one, it's like, have you had blood tests done? Yes, no. Well, most people have had a blood test done at some point in their life, right? So there are, and if so, were there any abnormalities? Well, first of all, abnormalities is a word that's hard for people to understand, and it's really small, and you have this little tiny space to write it in. People can't fill this stuff out. And then sometimes, like, do you use drugs? Do you have unprotected sex? It's like ever or never or when. So I may have been an injection drug user for 20 years, but I'm not now. How do I answer the question of, do you use drugs? And another thing that happens with the electronic medical record system is, people are often standing aside and asking you these series of questions about your health and your health behavior and your family, and they're just like clicking through screen after screen and not really engaged with the patient, and that can really turn the patients off. And then I also have had people work with us who say, they kind of are a little less willing to answer the questions when they know their answer is going into this into the quote unquote computer, because they feel like those answers are going to live on in eternity for everyone who ever cares for them to see. And while the provider they're talking to at the time may seem fine, the next person who opens up that information and sees that maybe they have a history of injection drug use, or their immigration status is questionable, that they may judge and perceive them and not care for them appropriately. So now I want to move kind of quickly to primary prevention, and that's stopping infections before they happen, and really meeting people where they are. Where are the people that are most likely to become infected with hepatitis B in our country? And having systems in place for awareness, education, and immunization where these people are. My program offered immunizations at drop-in centers for people who are in need of housing, for drug treatment centers, at syringe exchange programs, and at other cultural centers. And what we find is people are engaged and interested in immunizations. They want services that can help protect their health. I have people who have been homeless and walk around with a cart for 5 years, but they still have their immunization card because they got 2 doses of their hepatitis B vaccine at a syringe exchange program 3 years ago or 5 years ago. And they want to make sure that they keep that record of that, right? So people are very engaged. They'll line up early, they'll wait a long time. They do it without any incentives. And at cultural centers, we find this is where people are likely to have language support. And that's really helpful when you're trying to engage people that don't speak English or speak a language that's not common. Something else that we've noticed is that we often have a really high rate of immunization completion. right? So the series of doses for hepatitis A and hepatitis B vaccinations, we have a very high rate of return because people come back to the syringe exchange programs, people come back to their drug treatment centers, people come back to their cultural centers. And so it's a lot easier to find them again and make sure that you can complete the series than is often available at a primary care center. And we've learned that many primary care providers don't recall people. They don't give you a call to remind you to come back in for adult immunizations. For secondary prevention, finding those who are already infected, we need to do this in settings where people are, again, and in settings that are somewhat judgment-free, where community leaders or leaders within the various settings demonstrate the value of screening and testing, and perhaps will be seen doing it themselves. And tertiary prevention, assisting those who already have hepatitis B. How can we reduce further morbidity and mortality from hepatitis B? And again, what can we do outside of the traditional healthcare system? And I would say it would be great if we could all take a harm reduction approach. What can we do now to help somebody while we wait for the ideal situation where they can engage in an informed and supportive provider? So what we can do outside of that traditional medical care system is develop ways to help that person obtain insurance coverage or to find sites of care for the uninsured, to set up support before we link a person to a care provider, making sure that transportation is available and the person knows how to do it, making sure that there's language support and that that's set up before the patient gets to the provider so they don't perceive that they're a burden and leave. Finding healthcare providers who are experienced and knowledgeable in hepatitis B care, but that are also willing to take a harm reduction approach. Recognize that there's real and perceived stigma out there, and the patients have experienced this in the past and may be viewing their interactions with the provider with that lens. Recognizing when the hepatitis B services that they're recommending are not necessarily the most important thing in that person's life at that moment. They may have lots of other factors that take priority, like how are they going to feed their kids tomorrow, right? So not getting upset when someone doesn't act instantly on their recommendations. And so help prioritizing steps in care. What do we need to do now? How can we make that happen? And then recognizing how public health systems and medical care systems sometimes kind of get in the way, right? And trying to get to the ideal services, they lose sight of the good services. How can the CDC and local health departments help facilitate engagement and partnerships where traditional care providers who have the services and the support to provide immunizations, for example, can work with those community agencies where people are? And do this ahead of time, not when there's an outbreak, as has happened recently in recent years with hepatitis A and hepatitis B, but before that occurs, right? How can we work so that some of the requirements to participating in immunization and screening programs that are supported and funded by health departments, how can we reduce the burden of some of those requirements, either through partnerships or by just having some exemptions once in a while so that the good can occur. One such thing is immunization information system requirements. Many people who we've served do not want their information to be placed in the immunization registry or the IIS. And they say they don't want it to be linked to where they got their immunization or who provided it to them, because it's going to always inform anyone who looks at it that they were in a drug treatment program. So can we do something about that requirement? Have some exemptions here and there so the person actually gets protected. And then for medical care providers, training the upfront staff to be as friendly, as accepting as you are. The first encounter sets the tone for everything else that's going to happen in that visit. And reducing your waiting times. Showing up for an appointment and waiting for an hour can mean the difference between somebody keeping their job or not, or someone having child care or not. So I'm going to end there because my time is up, but feel free to reach out to me with questions or concerns. Thanks.
Thank you, Dr. Jessup. Our final speaker for session 8 is Dr. Stacy Truskin. Dr. Truskin is the Chief Medical Officer and Director of Viral Hepatitis Programs at Philadelphia Fight Community Health Centers and is a faculty member of the Infectious Diseases Division at the University of Pennsylvania Perelman School of Medicine. Dr. Truskin received her MPH in Public Health from Yale University, her PhD in Epidemiology from Rutgers School of Public Health, and her MD from the University of Medicine and Dentistry of New Jersey at the Robert Wood Johnson School of Medicine. Dr. Truskin specializes in infectious diseases, HIV medicine, HIV and HCV co-infection, and internal medicine. She has an interest in public health, particularly the epidemiology of hepatitis C and identifying and overcoming barriers to testing and treatment. She recently completed a 3-year term of service as a member of the AASLD IDSA HCV Treatment Guidance Panel and currently serves as the Chief Medical Advisor to the National Viral Hepatitis Roundtable and is a member of the Technical Advisory Board of the Coalition for Global Hepatitis Elimination.
Hi, everybody. My name is Stacy Truskin. I am an infectious disease provider and the Chief Medical Officer at Philadelphia Fight Community Health Centers. And I want to share with you a couple of the lessons that we can learn from hepatitis C, and in particular, some of the programs that I've built, and how we can utilize those lessons to expand access to hepatitis B services in non-traditional settings. So the traditional referral model of hepatitis C and hepatitis B testing and treatment programs has really been for individuals who are in the community to seek care in a tertiary care setting. So really, individuals need to travel from their neighborhoods, their homes, to go specifically to an area where they may have subspecialty expertise. And this presents a number of barriers. There could be geographic barriers, there could be cultural barriers, trust issues that come up. And historically, this model has not really served us very well in both the hepatitis C and hepatitis B epidemics. Really, what we want to be thinking about are models of care that bring hepatitis C and hepatitis B care to the communities where patients are already accessing services. And this may be in sexual health clinics, in drug and alcohol clinics, within their primary care providers' offices, perhaps even pharmacies, needle and syringe programs, prisons, and community health centers, or even churches or other community gathering groups. The other thing that really needs to be done is task shifting. So historically, it's really just been the hepatologist and gastroenterologist, and to some extent, infectious disease doctors or providers like me who have provided treatment for viral hepatitis. But if we are going to adequately address both of these epidemics, we really do need to be task shifting. There are many different types of providers that can deliver viral hepatitis treatment, both primary care providers, addiction medicine specialists, and it doesn't need to just be MDs or DOs. PAs and NPs are more than capable of providing these services as well. They're excellent and oftentimes independent practitioners with their own patient panels that may only be moderately supervised by MDs or DOs. Specialists can often contribute by facilitating mentorship, education, and training, and particularly true for hepatitis B treatment, which I think there are still some barriers around embedding this in primary care practices, even starting with just the interpretation of serologies. There are many different settings that can deliver viral hepatitis treatment as well, thinking about different primary care offices like federally qualified health centers, drug treatment centers, prison and mental health clinics, and then really figuring out how we can utilize these embedded models of care. And not forgetting that our subspecialty colleagues are still often needed, but just in select cases, perhaps even with just those with advanced liver disease or other complicating comorbid conditions, or perhaps complex drug-drug interactions with other medications. So I wanted to just take the little bit of time we have together to talk to you about two programs that I oversee in hepatitis C, and think about how maybe there may be some common trends that we could adapt to the hepatitis B model as well. So at Philadelphia Fight, we have a program called See a Difference, and it really is a patient navigation model. And we utilize this model in settings where the healthcare setting is not quite ready to embed viral hepatitis treatment. And so what our navigators do is they obtain detailed contact information from the patient. It's not just about who do we get in touch with in case of an emergency, but also where do you hang out? Where do you cash your check? If you don't have a place to stay, where do you crash? And that way we figure out lots of different opportunities to get in touch with the patient if they don't have a stable phone. We will partner with different settings to pick up on the care cascade wherever they leave off. Perhaps they've provided antibody testing for hepatitis C, and then the team goes in and does confirmatory testing, or maybe the test has already been done and education, counseling, and linkage to care needs to happen. For patients that do enter into our navigation program and our See a Difference treatment program, we have a cross-disciplinary and multi-center weekly huddle. This is critical. And what I will tell you is that every place where we have successfully implemented a program, whether it be a navigation program or an on-site treatment program, the huddle is critical because it brings together all the stakeholders on this multidisciplinary team. We share notes, we share stories about the patient, we try to figure out where the patient is in their engagement. And if they're struggling, we are the safety net that then provides support to that patient, and will dispatch somebody that is in that multidisciplinary huddle to then go and help support the patient if they are struggling with a particular roadblock or hurdle. In terms of open scheduling and prioritized hours for newly diagnosed patients, we've tried to make ourselves as open as possible and as flexible as possible, so that even though the patient is coming to us in a federally qualified health center, we're still going to make it as simple as we can for them. We now are able to offer both in-person and telehealth visits. There is not much good that has come from the coronavirus pandemic, with the exception of now being able to offer telemedicine to our patients. And this has been a really extraordinary way to engage patients where they are, both physically and emotionally, and start to provide hepatitis treatment and care, both for B and C. We have as much capability to go to the patient as possible to provide all of those other ancillary services. So we have a mobile fiber scan. We have laboratory technicians that are able to go out into the community and draw blood. This is particularly helpful in pandemic times where we may be relying on a televisit with a patient, and it helps to have blood work. It helps to have that fiber scan present. And so that is perhaps the second best thing to embedding a provider right where the patient is to be able to provide all these wraparound services, but maybe just do the actual visit through a camera. We support the individual with one-on-one support, both through case management, as well as support groups, which are now held through a Zoom type setting. Very virtual. No longer are we getting groups of 10 to 12 people in a room together, but we've figured out ways to still function within the pandemic. We often will use a modified DOT model. Now, I want to emphasize that particularly in the hepatitis C space, it is not required, particularly in the simplified guidelines that the AASLD and IDSA had put out. You do not need to do modified directly observed therapy. For many of the patients that we care for, they are functionally homeless and don't feel safe keeping 30 days of medication on them. So in those situations, we will hold the medication on behalf of the patient, and they'll come in, they'll get their medication, sometimes a warm meal, and a little bit of a respite from the outside world. And like I said, we do blood draws often in the community setting. So we provide treatment for hepatitis B and C at all of our sites where we provide medical care, and we have different sites that we partner with to navigate individuals into care. So community-based testing programs, we have our clinical-based testing and treatment programs, and then we partner with the Department of Prisons in the County of Philadelphia to be able to link individuals to care, often upon release from the jail setting. And what I can show you is, this is an example of what our weekly care cascade looks like. This is pre-pandemic. And what you can see here is that we have a little over 50%, nearly 60% of individuals that have tested positive and have entered into the care program that we have, they have been successfully linked to care. Now, this is ever evolving, and what I can tell you is we've had fewer individuals that have received testing, but we have been able to link more and more to care through telemedicine. And so this is a great improvement over what you would see with the normal care cascade that we see nationally, where only about 15% to 20% of people are successfully linked to care. So this type of navigation program certainly works when you're navigating into a low barrier setting like a federally qualified health center. So just a quick plug there for this type of navigation model. Perhaps the gold standard really, though, is another program that we help to oversee called C Change. And this is Philadelphia's plan to eliminate hepatitis C, specifically among people who inject drugs. And this is the embedded HCV care model at 3 different sites. And so we work with the syringe service program, methadone program, and another federally qualified health center to really demonstrate that if you bring viral hepatitis treatment to the patient where they are already receiving their care, you can really accomplish extraordinary things. We have an enhanced technical assistance model that provides clinical training and collaborative workflow development. There's ongoing clinical consultation, which often takes place in the form of that huddle that I was telling you about, where we also talk about not just patient and individuals' cases, but workflow integration assessment, and then provide technical assistance, not just around the medicine, but around the process. And we support our entities in creating a reimbursable model, both by reimbursing the visits that the providers have with the patients, which may not seem like a big deal. However, if you're working, let's say, in a methadone program, and those patient interactions have historically been reimbursed through a mental health payer, it is a bit of a task to get that reimbursed through a physical health payer. And that's something that we have supported our partners with as well. And then some of them have even gone on and gotten 340B accreditation to tap into that pharmacy benefit as well. We do have an embedded care coordinator that's on site that manages patient movement through the care cascade, phlebotomy, which is setting dependent, and we do provide one-on-one support to the patient. This is just a quick note about that 340B program. For those of you who are not aware, it does enable covered entities to stretch scarce federal resources. And manufacturers that participate in Medicaid agree to provide outpatient drugs to covered entities at reduced prices. So this is the data from one of our sites. This is Miraki, which is the largest methadone program in the city of Philadelphia. And what I want to show you is that among those that are RNA positive for hepatitis C, 85% of them have had a prior authorization submitted, and 97% of those individuals have had treatment initiated. So just goes to show, if you embed at a site, you really can do extraordinary things. And this care cascade, just like the other one, is evolving over time. So the lessons learned from hepatitis C treatment models that can be applied to hepatitis B, you really do want to simplify testing and getting as much of your laboratory data up front as possible. That reduces the number of phlebotomy sticks that you need from a patient, and it also allows somebody to engage in the care cascade up front. Bringing as much of the care to the patient as possible, whether that moves it to where the neighborhood where they are, so they can get it at their primary care provider's office, thinking about church groups and other high prevalence or public health or medical settings is really critical. And then thinking about task shifting, making sure that it's not just subspecialists, really gearing up to make sure all the primary care providers can be treating, in addition to addiction providers and others. So thank you for your time and attention.
All right. Well, thank you to all of our speakers, and welcome to all of you now live with everybody here today. We have a lot of questions that we can go through with each of you. And I do want to mention to the audience, there is an option in the menu tab on, I think, the left of your screen. I'm not entirely sure, but you can reach out to the speakers directly if you have questions that you would like to follow up with them about, or have further conversations about some of the programs you might be doing in other areas of the country and the world. So I think I'm going to start off with one of our questions, and I'll direct the question to Jeff and Alyssa first. So, do you plan to create the website in other languages? I believe there is a large Southeast Asian population in Rhode Island. Maybe you guys can talk a little bit more about your plans with the website.
Yeah, absolutely. We had just done English and Spanish to start based on funding and resources that were available to us, but translating to other languages and being able to reach broader populations is definitely on the horizon, and something that would be possible with further funding and student help and other resources as well.
Great. And Dr. Bratberg, do you have any other plans beyond that?
Yeah, I think it's really been great to create websites and be able to advertise them at pharmacies and give people the choice to engage in their own care and make them aware. And we did see hits on the website corresponding to the study, and people are still looking at it as we talk about it. So I think that, yeah, with more funding, we can keep it going. I think the other limitation is the sites that we connect to from the English and Spanish site on the CDC. We need to find translations of those sites so that it's a cascade of correctly translated evidence-based information.
Great, thank you. And related to the site, one of the questions that came in was, would you be open to adding non-Rhode Island pharmacies to the map since it's searchable by zip code?
Yeah, definitely. The whole point of the project and the websites is to create a long-lasting resource for Americans to get vaccinated against hepatitis A and B, and just having, any pharmacies that would be on board and pharmacy staff that would want to provide these vaccines, we would absolutely want to include those as resources.
Great. And,
I would say that
while sorry, go ahead. No, go ahead.
I was just gonna say that I think when we see that only half of pharmacies stock Hep B vaccines, it's really important that when clinicians want to, and community health organizations and all these non-traditional sites also refer people to pharmacies, that we make sure that there is some knowledge of where the vaccine is going. Because if the patient is in that window of willingness to get vaccinated and it's not there, while we do see good completion rates, we need to get that first dose in, have that rapport established, have it there. And we saw that through maps of other harm reduction through pharmacies like naloxone or pharmacies that stock buprenorphine. If it's not there in this accessible resource, it's not an accessible resource.
While we're on the subject of community pharmacies, for those in the audience who might be interested in maybe collaborating with pharmacists and pharmacies in their area, what recommendations would you both have for initiating that collaboration?
Dr. Bratberg, do you want to start by answering this question? You've had a little bit more experience with collaborating with community pharmacies and other projects as well. So,
yeah, I think, well, my first statement is don't do anything in the next 6 months with your pharmacy, because they're giving 300 million vaccines, or are a large part of that, protecting healthcare workers' long-term care. That's happening this month, we think. But beyond that, I think you're going to build on what the federal government and state governments have really recognized as an essential resource for providing vaccines. And so hepatitis vaccines fit into that, or how they reduce harm reduction, or how they're connected to the health departments. So I think you're going to be able to find more connections to community pharmacies through some of those traditional and perhaps non-traditional ways, as pharmacies reach out to long-term care. Like, that hasn't really been a connection in terms of going in and vaccinating, or pharmacies who might go to underserved, marginalized areas and do mobile vaccination. They've done that small term. Now we've warp speeded ahead, to use a term, in terms of how connected communities are to community pharmacies. And as long as sustained funding and reimbursement come along with that, and recognizing pharmacists as providers of care and as pharmacists essential public health researchers and providers of service, I think that can be sustained in a really positive way.
Well, thank you. There's a question that came in for Dr. Truskin. You've been part of the IDSA and AASLD HCV guidelines project. From that experience, what suggestions do you have to do something similar to simplify HBV treatment? The current complexity is a barrier for getting people into care and treatment. If you could talk about that a little bit.
Yeah, it's a great question. And I think certainly as an infectious disease provider, the notion of treatment as prevention is one that we have missed in the hepatitis B world. The idea that if you are not viremic, you can't pass it along as easily to somebody else is missed in the current hepatitis B treatment guidelines. And so I do think that there are some significant lessons that can be learned from both the HIV and the hepatitis C world around approaching treatment in a different way, that it's not just about liver enzyme elevations and about the viral load thresholds. It's about just the presence or absence of virus and what that means for not just the individual, but for the public's health, and simplifying it that way. So it's a great question. I know that there are folks who are thinking about approaching and revisiting hepatitis B treatment from that perspective. I certainly hope they do. And I know that there are lots of folks like me that are advocating for that moving forward, but your point is well taken and I'm in agreement.
Thank you. I have a question I'm going to start with Dr. Jessup, but maybe a question for the entire panel. What other more strategic roles could insurance play in increasing access for hepatitis B screening and vaccination services? Is there a way that they can maybe streamline it and help make it easier in some way? Dr. Jessup, if you wouldn't mind taking the question first.
A couple things come to mind right off the top of my head, and these aren't true for every insurance plan, but for some, is they limit, who they will reimburse for different services. So what kinds of providers and which ones can be reimbursed for immunizations and testing? Is it only the primary care setting or not? And then I just lost my train of thought. Oh yeah, and not just in my head as I answered that, I was thinking of, their specific primary care provider versus a different established healthcare provider that can bill, but making it a little easier for some agencies that are non-traditional providers to be able to bill insurance if someone has it. So community agencies who may want to do this, or even established healthcare providers who want to do something out in the community. It's not as always easy to bill for those services. So I think that's one thing that could help a lot.
Thank you. And I'll just pose the question, what are some ways that insurance could be an advocate, I guess, in this space to the other panelists? So whoever wants to jump in.
I mean, I've done studies of insurance databases and have been involved in outcome studies about, cost effectiveness and prevention of liver cancer, death, things like that. I think the data's there. I think we need to work with policymakers and the insurers. And, in our state, in Rhode Island, we have an Office of the Health Insurance Commissioner who's a provider, and say, this is the time you will save money. We can do experiments in Medicaid and save money there. And so I think that, the data is there, it can be applied to a specific state's database, and then maybe we can go from there, just as our state eliminated all restrictions on hepatitis C access a couple of years ago to great effect.
All right, Dr. Truskin or Alyssa, if you wanted to weigh in, please feel free. Otherwise, we have other questions here that I can jump to as well. All right. Dr. Jessup, you spoke about a number of different settings that you've worked with. Would you be able to provide some maybe like top recommendations or strategies that these sites have put into place to ensure or help patients complete their vaccination series? And then to put Jeff and Alyssa on deck, are there concerns in the community pharmacy setting for ensuring that patients complete their series in that setting?
So one thing we found very helpful is we ask, as we're getting consent to do the vaccinations, we also have them sign things like, can we share this information that you were vaccinated here today with this, wherever the setting is that we are, whether it's a community setting, a church, a syringe exchange program, drug treatment program, and that would stay on file there at the center. So they can always come back and find out or get a copy of, what they got, what vaccinations they already got. And we try to, when my organization does it, we try to keep track and follow up with people, but again, it's hard to keep track of where they are and their phone numbers and stuff. So we can always go back to the setting where we vaccinated them first, and sometimes match up, who needs one and who's still there in the program, and use the community agency to contact them where we're not successful. So having that information in two places that the patient can access has been really helpful.
Thank you, Dr. Jessup.
Yep.
So flip question for Dr. Bratberg and Alyssa. What concerns might you have about completing the series in community pharmacy settings?
So this was actually something Dr. Bratberg and I had talked about, of why we had chosen community pharmacies for our location. And it's that these patients, this population is coming into the pharmacy each month to get their prescription. They have, pharmacists that are tracking when they're coming in, when their first vaccine was. And because of that point of contact and the relationship between a pharmacist and the patient in the pharmacy, we think that may increase the rate of vaccine completion for these vaccines with multiple series. And so some of the, obvious concerns that we would have for this not playing out as hoped or as, imagined would be if someone kind of dropped off and stopped taking their medication, or if they were disconnected from the healthcare system, weren't able to afford it anymore, things like that would prevent them from coming into the pharmacy and having that point of contact. That might be something that would prevent the optimal, scenario of completing the series in a pharmacy. I don't know if Dr.
I can build on that. I think. Yeah, I think that pharmacies, anyone who's picked up a prescription at a pharmacy has probably gotten bombarded by a request to download the app and give you your phone number and be texted when things are ready. And if you go to your physician, you're filling out paper and then 2 months later getting a bill. Billing is just different in pharmacies. And so I think we can come to the middle in terms of how providers, typical providers, non-traditional providers and pharmacies can use the success of how we do reminders. I'm laughing. I saw yesterday that the COVID vaccines, when approved, are going to come with a card to remind them to get their 21 or 20-day vaccine. And we had distributed cards and we said, nobody takes a card, nobody has a wallet, everyone buys things online and does curbside or whatever. But I think it's interesting to think that the government still thinks cards work, where pharmacies have gone to sort of a more automated EHR based, and now there's lifetime registries, I think, in all states. And so the registry itself needs to be built into that. And, we're using an app to record vaccine side effects. That could remind people, right? And I think Alyssa brings up a good point that any provider who doesn't have that second shot for often vulnerable, marginalized populations, that's a checkup for the things Dr.
Jessup has talked about in terms of reaching out for what's going on in their life, employment, transportation, and we're more acutely aware of all those things post COVID-19.
And Dr. Truskin, did you want to weigh in as well on maybe strategies that you've seen in practice that have helped ensure that patients are able to complete their series?
Yeah, I think just to follow up on the lifetime registries that communicate with electronic health records, that for us in the clinical setting has been just amazing progress, because we have patients that are linked to care from us from outside agencies or are coming to us from a prison or jail setting, and we can see now what they have gotten in the past, whether it's been at a pharmacy or another provider, and that has been a game changer for us in being able to pick up where somebody has left off. Because for somebody that has moved around a lot or has experienced homelessness, to remember the last vaccine they got and what it was for is a near impossibility. And so that has, I think, been the most helpful in continuity of care. And I know for us, we had upgraded our EMR a couple of years ago, and the module that allowed us to connect with our vaccine registry really just went active recently. And we have seen it in practice, what an extraordinary advancement it's allowed for us as providers and for our patients.
Awesome. I think these are great recommendations. I have a question that came through that I think is really interesting for the entire panel. What are some opportunities for integration with the build out of COVID vaccine infrastructure? So how do we move forward from that to help meet the needs for hepatitis B? Maybe I'll just start with Dr. Truskin, and then we can circle around.
Yeah, I think, again, it goes back to those registries. And if we're able to access those, as at least in the primary care setting like I work in, and we're able to bring folks in, because people, well, it's complicated because some people don't trust that the COVID vaccine is safe or effective. But once we get over or move beyond some of those trust issues, assuming people are coming in to receive the COVID vaccine, it is such an amazing opportunity to get them up to speed with their other viral hepatitis vaccinations. So particularly like Hep A and Hep B, it's really important. I know we haven't really talked about Hep A in the session, but like we have just sort of on the other side of that outbreak in many of our communities. And so the importance of getting vulnerable populations vaccinated there too. So I think that alone, the awareness of vaccination, a drive towards providers to receive vaccine, to allow us to look in those registries to catch people up and get them their vaccinations for preventable diseases is going to be amazing. So hopefully we don't miss the opportunity.
Agreed. Other thoughts? We're quickly coming to the end of our session, but other thoughts?
I think just even if it's in a more chaotic, mass vaccination sort of setting than a primary care setting, to make sure that other vaccinations are discussed and the need for them, at least information provided to those getting vaccinated, that this isn't the only issue you need to worry about today. I'm say better than that. The only issue you need to worry about today, but there are these other vaccines available that can help you. It's taking any opportunity to even awareness, if not actual vaccinating people.
I would say that if vaccination is normalized everywhere, if anyone everywhere is saying, we care about you, you care about your community, we care about our community, let's get vaccinated. If the attitude does shift from one of hesitancy to one of life really depends on us caring about each other, and vaccination is one of those things, we can draw on that empathy and realize that I don't need to go to a doctor's office or a pharmacy. I can go to a point of dispensing or a school. We saw that with H1N1 in 2010 when I helped with efforts there. Didn't seem unusual because we deliver education in a school, we can deliver health in a school. We know that from COVID. We deliver lots of things through schools, and we deliver lots of things through federally qualified health centers and primary care and things. So I think you'll just see an expansion of public health and social health, essentially, into really more settings more permanently.
All right. Well, thank you for spending time with everybody today. I think this was an amazing presentation altogether, and I'm sure we could all continue chatting for hours if a lot of the time, but we do not have it today. So I'll just close by saying thank you, and I hope everybody enjoys the rest of the summit.
Hello, everybody. Welcome to our next session, which is Bias and Racism Create Significant Disparities in Healthcare. What will you do about it? My name is Chioma Nnaji. I'm a program director at the Multicultural AIDS Coalition, which is located in Boston, Massachusetts. I'm very excited to be here with you. Today we are joining for this very critical and timely, some would say long-waiting conversation, especially with our work in hepatitis B. We will build from the introduction session that we did on Wednesday. If you were not able to attend Wednesday, that is totally fine. You will catch up. This is an interactive session. So you will be engaged in self-reflection. You will be engaged in the ways in which racism and biases show up in your work. And so we ask that you please be ready to really engage with our conversation in a very authentic and sincere way. You will also be promoted for prompt for discussion in our chat box. So look in the chat box, talk with each other. In addition, we'll be open for questions. And so there will be different times during this session in which you will be able to pose questions. So Dr. Bernard Lopez will be taking us on this journey today. Dr. Lopez is a professor and executive vice chair in the Department of Emergency Medicine at Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia. Since 2013, he has served as the Associate Dean for Diversity and Community Engagement in the medical school, providing oversight of diversity and inclusion initiatives for faculty, graduate medical education, and medical students. Most recently, he was added as the Associate Provost for Diversity and Inclusion at the university. And so we are excited to have him in guiding us. Dr. Bernard Lopez, welcome.
Great. Well, thanks. It's good to be back. I'm hoping that I had the chance to meet many of you, granted virtually, but hoping that many of you attended my session on Wednesday. Wednesday was you might say, a brief introduction to the different topics. Really, the topics were unconscious bias, microaggression, and race. So I had 30 minutes to cover all of those. Well, what we're going to do today, again, for those of you who weren't able to make it, I've got refresher slides here. For those of you who were able to make it, well, you're going to see some of the same slides that I used, but we're going to dive much deeper into each of these areas. So really, the title of this talk is really looking at bias and racism, because they affect the care that we provide to our patients. And really the big question for us here, it's really a question for all, but certainly a question for those of us who are here today is, well, what can we do about this? All right. All right, so if we could play the first video.
Hospedeira, arranje-me outro lugar.
Minha senhora, a classe económica está lotada.
Desculpe, eu não vou viajar ao lado do negro. Faça qualquer coisa.
Eu vou falar com o comandante. O comandante manda dizer que conseguimos arranjar lugar na primeira classe. E pede imensas desculpas. Realmente é inconcebível um passageiro viajar ao lado de uma pessoa tão desprezível. O senhor acompanhe, por favor?
So I showed this video on Wednesday. The idea being that when we hear the word bias, even unconscious bias, this is often what may come to mind. What often comes to mind is overt racial bias. Clearly, that was an example of that. That wasn't an example of unconscious bias, but these are sometimes the things that we think about when we hear those words. I mentioned this book by Howard Ross from Cook Ross Incorporated, a friend of mine, a company that does a lot of work in this area, but we do live with unconscious bias. It's with us all the time. Certainly during our waking times, it's with us, and it affects our everyday actions, our everyday interactions. The neutral definition of bias: a tendency or an inclination that results in judgment without question. So our biases, our unconscious biases, allow us to function, allow us to go into action without really much thought. And fortunately, most of the time, our unconscious biases serve us well, but they can also serve us in a negative fashion as well. The purpose of bias are, first and foremost, our unconscious biases serve to protect us from harm. So they're built into us as human beings. We see a dark, shadowy figure. We're by ourselves. It's late at night. It's a dark street. You see a dark, shadowy figure. Well, our unconscious biases allow us to go into immediate action. We turn, we run, we protect ourselves from harm. That is the function of unconscious bias. So it's built into us. It's part of who we are as human beings, largely because it serves to protect us. Again, the hope is that we're not living in these sorts of situations on a regular basis. Really, it functions, yes, to protect us, but mostly to allow us to function on a daily basis or with our everyday actions. I gave a couple of examples of how unconscious biases can make complex situations even more complex. So I used this example of biases that physicians may have. I have my unconscious biases. Is it possible that I'm in some way biased against the patients that I care for? Well, yeah, it is. It's extremely likely. Again, not in an overt way, but typically in an unconscious, in an implicit way. Our patients, by virtue of them being human beings, so patients, people that you care for, that you work with, also have their unconscious biases. So you can take complex situations, and when you layer on top of this unconscious bias, it just makes situations even more complex. We have biases. It's not do we have biases, but what are our biases in all of these different areas? So we have biases, again, typically not overt, but it's commonly unconscious or implicit. But question is, not do we have them, but what are our biases? The way this works, again, I showed these on Wednesday. You see something, a person, a situation, it goes through the lens through which you view the world. That lens is really made up from our past experiences over a lifetime. It's constantly being shaped by the experiences that we have going into our fast brain, our emotional brain. We spend 80% of our time here. We see something through the lens through which we view the world. We act and react. And typically with some emotion, we're there 80% of the time. About 20% of the time, we actually use active thinking, the slower part of our brain, the thinking part of our brain. But most of our actions and reactions happen very quickly and occur about 80% of the time. So with that, again, that's kind of a refresher from what I presented on unconscious bias on Wednesday. What I'd like to do, I have a video here. This is a video that we produced at Jefferson. This was done with Dr. Emile Bruno. Unfortunately, the late Dr. Emile Bruno. Dr. Bruno was a cognitive neuroscientist who did a lot of work in the area of unconscious bias and the neurophysiology behind it. We created a video that will give you a little bit more detail on unconscious bias and how it actually works. So if we could play the video.
Most people think our brain's job is to give us the most accurate, high-fidelity readout of the world possible. A pepper is a pepper, a backpack is a backpack, a mop is a mop. We want to believe that we see things exactly as they are. But a neuroscientist would say, that's exactly wrong. The brain is actually riddled with a whole set of prior assumptions and biases that have been baked in through evolution. Take the visual system. Let's say we see this image. Our brains very quickly recognize it's a backpack. We process this instantly and unconsciously. But at the same time, we also see a face. Our brain processes the face just as quickly, automatically, and unconsciously as it did the backpack. This is an optical illusion generated by our unconscious brains that demonstrates a bias in the visual system. Our brains are so primed to see faces that we often see them where they don't exist. Here's another optical illusion. This is a two-dimensional image, but why does it look 3D, like one of the dots is coming out at you? Look what happens when we do this. Now, all but one looks like it's coming out at you. So it's not the image that's doing this work, it's our brains. This reveals a prior bias. Our brains see the circles that are light on top and dark on the bottom as bumps. This is because our brains assume that the light source will come from above. So why would we assume that? Because, you guessed it, the sun. This assumption is ingrained in all of us. Just like seeing faces and objects, our brains are constantly creating this illusion all day, every day. Now let's look at this rectangle. It may look like all one color, but it's slightly lighter on the right side. Look what happens when we do this. Now our brains trick us into thinking the contrast is stark, even though in reality it's very slight. Our ability to see contrast is what helps us see objects discreetly and to distinguish objects from their background. Seeing contrast like this is actually a key to our survival, as you will soon see. So it's a good thing our brains are doing this unconsciously every waking moment of our lives. And we don't even have to work hard to see these optical illusions. This all happens in a snap. In fact, some of these biases are how we prove that we are human on those online forums. It's very difficult for an unbiased computer to read the CAPTCHA text, but it's easy for us. This illustrates something very important about the brain that's captured by an analogy. The brain is like a rider sitting on top of an elephant, where the rider represents the small part of our brain that we're consciously aware of, and the elephant represents the vast majority of the processing that goes on in our brains, but that we're completely unaware of. The elephant applies these biased filters to incoming information, so data can be processed very quickly. As a result, our brains see things that are not there. They don't see things that are there, and they ignore some features and accentuate others, all without our awareness, endorsement, or permission. And yet, the question remains, why? Why does our visual system have these particular biases? It's simple. Brains that see this immediately as a lion are not eaten. Brains that don't see this as a lion or process it too slowly become dinner. We all have ancestors whose brains had to pass this test, and we all must understand that these biases will affect every human interaction we ever have. So it's important we learn more about them.
I'm going to talk to you today about what neuroscience knows about the biological basis of bias. My hope is to leave you with some understanding about what unconscious biases are, why they exist, and what we can do to reduce them. The human brain has this crazy monumental task. It has to make sense of tens of millions of bits of information that hit it every second. Our brain deals with this in a couple ways. First, it processes most of the information behind the scenes and below our conscious awareness. And second, it ignores or completely distorts much of the information coming in to fit prior assumptions. If we think of the brain like a rider sitting on an elephant, the rider represents the small part of your brain's processing about which you're consciously aware, while the elephant represents the vast majority of processing happening in your brain that you're completely unaware of. It's the unconscious brain, the elephant, that a number of the assumptions reside in. Some of the assumptions are built in, others we learn over time. Since we're generally unaware of these assumptions, we refer to them collectively as unconscious biases. In the visual system, we can identify these unconscious biases through optical illusions. Our brain exaggerates some visual features in the world and completely ignores others. It does this effortlessly and without our permission or awareness, making us see things not as they are, but how they're most useful to us. But unconscious biases are not limited only to the visual system. They're also present when processing information about the people around us, our social worlds. These biases can be revealed through what we might call social illusions. One of the most fundamental social illusions is the tendency to think not just in terms of me and you, but in terms of us and them, sometimes called tribalism. This tendency towards tribalism is so strong that when children or adults are randomly assigned to totally meaningless groups, for example, if half the people in a room are given red shirts and the other half are given blue shirts to wear, they start to favor their own group members. If they're in a red shirt, they tend to think of other red shirters as more attractive, intelligent, more trustworthy. And they give more resources to red shirters than they do to blue shirters. Again, even if they know the group distinctions are completely arbitrary. And once a tribal distinction has been drawn in the mind, other biases start coming online. One of these biases is called the fundamental attribution error. When someone misbehaves, we look for a reason why. The fundamental attribution error describes the tendency to blame anything bad I do to the situation. I was speeding because I have an important meeting to get to. While we tend to blame anything bad other people do to their disposition. They were speeding because they're a maniac. This tendency extends to other groups. For example, if a politician from our political tribe is caught lying, we tend to explain it away. They were just mistaken. Whereas when a politician from the other political tribe is caught lying, we see it as a window into their soul. They are a liar. This is not to say that either view is wrong, just that our brains nudge us to interpret every ambiguous interaction in this way. Another important social illusion is called confirmation bias. Confirmation bias is the tendency to seek out information from sources that will confirm what we already believe to be true, and to accept that information totally uncritically. Consider this headline: "Death penalty prevents crime." If you're against the death penalty, you're more likely to scrutinize this article for any inconsistencies and dismiss it entirely if you find anything dubious. This is confirmation bias. One study demonstrated confirmation bias by taking people who were for the death penalty and people who were against the death penalty and presenting all of them with the same strong, well-supported research that showed that the death penalty did in fact prevent crime, that it worked. They also gave the people critical reviews of that research. What they found is that people who were for the death penalty selectively paid attention to the research and discounted the critiques. And people who were against the death penalty paid attention only to the critiques and discounted the research. As a result, both sides were more extreme in their original views. In other words, our brains are built with an unconscious tendency to hear what we want to hear and disregard the rest. As with optical illusions, these social illusions and many others are automatic and baked into our unconscious brains. It's like your brain has different filters that it applies automatically to incoming information based on the source. When your brain's attention is on us, it automatically applies the enhanced filter, which makes you see in-group members as slightly more kind and virtuous and well-intentioned than they actually are. When you perceive them, your brain applies a different filter, which makes you see out-group members as a little bit nastier, more wicked and ill-intentioned than they actually are. And the filters don't have to be wildly different to make a huge impact over time. If you think about it, if every image your mind takes your entire life paints us a bit more noble than we are in reality, and them as a bit more vile, you begin thinking that this is the way we and they really are. As with our visual system, these social illusions were shaped through evolution long, long ago. For hundreds of thousands of years, our human ancestors formed small tribes that fought fiercely with each other. 15% of every generation died from warfare for hundreds of thousands of years. Dividing the world into us and them helped our brains at that time navigate and survive the cutthroat world. But the diverse cooperative communities we find ourselves in now are very different from those which our ancestors' brains were shaped. In many ways, our unconscious brains have just not yet caught up. As a result, we now find ourselves trying to solve 21st century problems with Stone Age psychology. So this all paints a totally disheartening picture. If we're born with these biases, and they're beyond our conscious awareness, what on earth can we do about them? Well, fortunately, tribalism is not our only evolutionary legacy. We've also inherited the ability to exert an incredible amount of control over our unconscious brains. There are 100 trillion connections between nerve cells in our brains. And these connections are not only able to change, they're fundamentally designed to do so. Our brains are not static. They're not hardwired. They're plastic and elastic and always able to change. But how? How can we direct these changes? How can we be less reliant on or even transcend these social illusions? Well, psychologists and neuroscientists have identified some promising approaches. For one, it turns out that for some biases, even just becoming aware of them can enable us to pull them into conscious awareness and then reshape or reject them. Some biases we can dispel once we learn about them, like this. Others may require a bit more effort and time. But what's been learned through repetition can also be unlearned the same way. For example, when white participants were asked to practice thinking in terms of individuals rather than groups, or if they simulated in a simple video game repeatedly approaching black characters, their prejudice towards black people in general was reduced. Attribution errors can also be corrected with practice. In an experiment, white participants were given negative scenarios about black people and asked to select a reason for each behavior that was situational rather than attributional. For example, if they were told that a person was late for an interview and given the following options, either they're lazy or their power went out and their alarm reset, they were asked to choose the situational explanation each time, in this case that the power went out. They then repeated this exercise a number of times with different scenarios. The researchers found that just a few minutes of this attributional practice again improved attitudes towards black people in general. These effects were observed in these really simple little exercises. So imagine what could happen if we make the conscious choice to change our habits of thought. What if every day we reminded ourselves of our unconscious biases and gave ourselves little drills to retrain our brains? Changing habits takes effort at first, but as with learning to shoot a basketball, learning a new dance move, or learning to knit, it becomes easier and easier over time. With enough practice, we can make unwinding these social illusions just as automatic and unconscious as they are right now. We asked you at the beginning, what are unconscious biases? Why do we have them, and how can they be reduced? Hopefully you have a few answers to these questions now. We know that our brains lead us to tribalism and to apply different standards to our own group versus other groups. As a result, we're awash in hypocrisies and inconsistencies. We condemn members of other groups for the same exact actions we forgive coming from our own. A biased brain, though, is not abnormal or pathological. It's just a consequence of being human. This should give us some humility. But just because we're born with bias, we're not off the hook, because our brains are also incredibly flexible. They're not only able to change, but they're fundamentally built to do so. So there are a few common responses to learning about your own unconscious biases. We may feel ashamed that we harbor views that we don't condone, or we may feel resigned to biases that are baked into our brains. I want to offer an alternate response. Be fascinated with your biases. Be enthralled. Be excited when one of them is revealed to you. Because once you've learned to recognize them, then you can work at dismantling them. But if we fear what is in our minds, or feel ashamed and uncomfortable when it emerges, we have less opportunity to change. Remember, a biased brain is not abnormal or pathological. It's a consequence of being human. But while unconscious brains may be pre-wired with bias, nothing is hardwired. We have the potential to intentionally shape our unconscious mind and also the ability to gain conscious control over its processes. In fact, now that we know a bit about how our brains work, it may be our duty to change them. In the words of a wise scientist, those who have the privilege to know may have the duty to act.
We all have biases ingrained in us, whether it's seeing faces where they don't exist, seeing the world with an us versus them mentality, or seeking out information that confirms our biases. These biases in our visual system and social cognition are all part of what makes us human. Sure, they can do some good, like help us survive, but they also do us a disservice. Our brains filter information unconsciously and can exaggerate the differences between us and make us assume the worst about people that are different from us. Neuroscientists are right. We don't see things exactly as they are. We see things as we are. But here's the good news. Even though the elephant, our unconscious, takes in information through these bias filters, once the writer knows about them, we can learn to make conscious decisions to transcend and overcome these biases.
So I'm hoping that you are, just as Dr. Bruno said, that you are enthralled, you become interested. It's part of who we are as human beings. It's okay to be biased, otherwise we wouldn't be human beings. Some of you may have taken or heard of the implicit association test. This test has been around for over 20 years. It's perhaps one of the most studied tests that exist, certainly the most studied test in the area of unconscious biases. Millions of people have taken this test. A lot of research has been done on the results. So really, this test is designed to, again, investigate thoughts and feelings outside of our conscious awareness and control, hence the implicit or unconscious bias association test. It was established in 1998. Often it's known as the Harvard implicit association test. So here's one of the interactive pieces of this session. There are 14 implicit association tests. The most recent one is on presidents. Sometime on your own, you might want to explore some of these tests. They're actually quite interesting. Even if you've taken this test before, I want you to take this test now. So I know most of you are at a computer, and based on how this particular platform works, it looks like it's actually going to be pretty easy to get to the implicit association test. So we are going to take the race implicit association test. If you've taken it before, take it again. We're going to talk about what it means and how you compare it to previous tests, but we're going to do the race implicit association test. All right, don't worry. You won't get any, well, I don't know how you tell, but you won't get any advertisements or more spam email. It's a confidential site. I want you open a browser. It's pretty easy to do, or it's much easier to do on a computer than it is on a smartphone. Go to implicit.harvard.edu. So implicit.harvard.edu. You're going to take the race implicit association test. So they're going to ask you some questions. Again, it's anonymous, it's confidential, but it's anonymous. They're going to ask you some largely demographic information, but I want you to take the race IAT. When you're finished taking it, there will be a result that you will get. And then what we're going to do after you've taken the race IAT, we're going to talk about the results and what that may mean. All right. So I am going to give you 12 minutes to do it. 12 minutes plus or minus. I'm going to give you 12 minutes from this point to take this test. Do it as quickly as you can. Just do it, and then we'll talk about the results. So 12 minutes from now. All right, so I'm hoping most of you, given that maybe some technical issues, but I'm hoping that most of you had the chance to get through the implicit association test. And if you didn't, I'll talk slowly, but if you didn't, please continue on. I think it's really important that you end up seeing what your result is for this particular test. All right, so in the race IAT, you came up with a preference, or you will come up with a preference of white over black. So you came up with one of these three: strong preference, moderate preference, and slight preference, right? Conceivably, you could actually have preference of black over white in the same. But typically what will happen when somebody takes this test, and this goes for everybody, typically what happens is you end up with strong, moderate, or slight preference of white over black. So what I want to share with you is my experience with this particular test. It was probably, I don't know, maybe a year and a half into my time as the Associate Dean for Diversity and Community Engagement. I wanted to use this tool in teaching unconscious bias, and I took the test. And the first result that I got was strong preference of white over black. So my initial reaction was, this can't possibly be. I must have done something wrong. And I can tell you, in my heart, I didn't feel very good. There was a lot of anxiety around that particular result. So I took the test again, and I took it again. I took it again. I took it 5 times, one right after the other, because I thought I was supposed to at least get something neutral, certainly not strong preference of white over black. If you assume that the gold standard, that the ideal is neutral, well, the best I could ever get it to was moderate preference of white over black. Initially I thought they have the wrong person for this job, and I couldn't believe it. How could that be? Those aren't my values. Well, what this test is, this test is really meant to raise awareness of unconscious bias. It is not a measure of bias. It's not a measure of prejudice. So if you think about the lens through which we view our worlds, and you think about the experiences that we have, you think about all of the things that shape our experiences, well, it's the visuals that we get. Well, think about our society alone. Well, what does our society, what are the messages that we get regarding preference of white over black? Well, if you imagine, many of the images, the majority of the images really favor white over black. So what the IAT actually measures are the unconscious biases. It really, in some ways, measures how we have been conditioned. Think of it that way. Right? I mentioned that there were 14 implicit association tests. When you look at that list, you can imagine what your results are going to be based on the society in which we have gained most of our experiences. So the reason I like doing this in a group, sometimes people say, why don't you have everybody do it on their own? And then you'll come back. Well, what happens when people do it on their own is they take it and they can get very defensive. They can't believe this happens. That's not me. I just wanted to be able to demonstrate this in you, just to give you that experience, but to let you know that these are unconscious biases. It doesn't mean that this is your overt behavior, but just know that they're there. So it's not a measure of prejudice or racism. It is simply there to raise awareness about unconscious biases. All right, so I showed this slide on Wednesday. microaggressions. When you think about the unconscious biases that we each have, well, think of microaggressions as a more active form. Again, it's still unconscious, but this is more of the action that may result from unconscious biases that we have. Typically, they are unintentional. Microaggressions are not intentional. If they were intentional, then it wouldn't be micro, it would be a macroaggression or just an outright aggression. But these are verbal, behavioral, environmental slights. Again, typically unintentional, that in some way communicate hostile, derogatory, or negative slights and insults towards certain groups of people. Each one of us have experienced this, some more than others, some more regular than others, but you've experienced, you've done a microaggression. Again, it's typically without your even knowing it. So one of the important reasons for understanding unconscious bias is you want to minimize microaggressions, because these microaggressions will influence our interpersonal interactions, our relationships. They will influence our behaviors and our actions. All right, so we're going to switch now. We're going to switch from unconscious bias. You've had a little bit of an experience. We talk a little bit about microaggressions. I'm going to switch into a different part of this. It was bias and racism. Why don't I go into the racism piece? And I introduced the topic on Wednesday, and we're going to go just a little bit deeper here. All right, so race and racism. It is the elephant in the room. All right, it is a huge topic. It's a pervasive topic. Yet it's typically a topic that nobody really wants to talk about. We need to talk about it, but we don't really want to talk about it. Why? Well, it's very uncomfortable. We're afraid of saying the wrong thing. We might offend somebody. We don't believe that it actually exists. After all, in 1965, there was the Civil Rights Act. We must clearly be beyond this. Well, the reality of it is, you pay attention to the news even today, it's not over. It exists within our society. It exists within us, but it's the elephant in the room. For those of us who are, this is a conference on hepatitis B. We do with the people that we care for. Well, we like to think that we're doing, that the work that we do and how we behave is based on science and not something like racism. So it couldn't possibly be involved in our interactions with the people we care for because we use science, correct? Well, here's what's going to happen. I'll just give you a little bit of warning about what will happen as we get into just a little bit deeper of a conversation around race. All right, so what happens? It kind of goes back to that unconscious bias, the neurophysiology slide that I showed you earlier. All right, so you see something, you're going to see things, you're going to hear things. It's going to go into your fast brain. It's going to go into your amygdala, cingulate gyrus, hippocampus. There's going to be actions that happen from this. Well, there's something called the amygdala hijack. You see something, you're going to see and hear things that may just simply take over your brain. All right, you're going to get defensive, you're going to get angry. This has the potential to really not let you take in new information, process new information. So just a word of warning, just be aware of the amygdala hijack as we go through this portion of the talk. Race, all right, so I showed some slides earlier. This is perhaps the first classification of race. Pre this, people were classified in different ways. It wasn't commonly by color of skin. It was, kind of like political status. It was civilized versus uncivilized. Previous to say a classification such as this, there really wasn't much consideration given to classification of people by color of skin and physical characteristics. So on Wednesday, I talked about Carolus Linnaeus, who came up with this classification of people, dividing people up. You can see the different divisions here, and you have a pretty good idea of what those groups are today. But this is one of the first descriptions of race based on physical characteristics. Interestingly enough, Linnaeus also added in some classification based on observed or perceived behavior of these big groups of people. So Americanus, regulated by customs; Asiaticus, ruled by opinions; Africanus, governed by caprice; Europaeus, governed by laws. Again, some classification based not just on physical characteristics, but on perceived behavior. And then I mentioned that a student of Dr. Linnaeus, Johann Blumenbach, classified people based on the appearance of the skull. And this may have been the first sense of hierarchy, that the Caucasian skull was the most beautiful form of the skull from which others diverge. So there's some idea of superiority and perhaps inferiority. Thomas Jefferson, in his book, The State of Virginia, he states outright, I advance it, therefore, as a suspicion only, that blacks are inferior to whites in the endowments of body and mind. So here's a statement that suggests superiority, and, or rather in this case, inferiority based on race. All right, races. I know this may be repetition for some, but I think it's important to hear these. Racism is a system of structuring opportunity and assigning value based on one socially ascribed category, that being race. A characteristic of racism is that its effects can persist in governmental and institutional policies in the absence of individual actors who are explicitly racially prejudiced. So racism doesn't depend on individuals. We often think of racism as an interaction, one person saying something against another, but in reality, racism doesn't need the people. It's the structures that are in place. And then that goes into this particular definition by Dr. Kamara Phyllis Jones. Structural racism it's a system of structuring opportunity and assigning value based on race. And what this does is it unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities. And ultimately, by virtue of the fact that you're advantaging one and disadvantaging another, you ultimately undermine the full potential of a whole society, because you're not taking advantage of all of the human resources, all of the people that are there. So that's structural racism. Again, it doesn't depend on individuals. This is a structure that's in place. I mentioned this is not something that has just happened. We're going to look at 400 years or so, maybe 405. You think of 1619, when Africans were brought over as slaves, and you think that there's perhaps close to about 350 or so years of slavery. Slavery is abolished. There's this period of time, segregation and Jim Crow, and then there's the Civil Rights Act of 1965. So racism has been with us for hundreds of years. It didn't disappear with the Civil Rights Act. It didn't disappear in 1865 with the abolishment of slavery. It simply changed. So just to give some perspective around it, this is how long it's been around. And this is why it's often not easy to combat, and it's certainly not easy to talk about. I'm not sure. I'm hoping many of you, if not all of you, have had the chance to play the game Monopoly. It seems like everybody's had the chance to play Monopoly. So one way to equate systemic racism is to use the example of Monopoly. So we're going to play a game of Monopoly. We're going to play a game what we're going to do is we're going to, let's rough estimate 400 years. We're going to play Monopoly for 35 minutes. We're going to play a total of 40 minutes, but for 35 minutes, what we're going to do is this. We're going to play with two different sets of rules. If you are an underrepresented minority, specifically if you're Black, you're going to play with a different set of community chest and chance cards. You're going to have more go to jail cards. You're going to not have as much money. You're just going to have a different set of cards. You can only buy in the first row and a half. So you can only buy properties in there. You can't buy properties on that last row with Boardwalk and Park Place. When you pass go, you're not going to get to collect $200. So we're going to play this for 35 minutes. That will represent the 350 years of slavery. Then what we'll do is we'll switch things up after 35 minutes, right? So Civil Rights Act, we've got some policies, some laws in place. So let's play under a different set of rules. We'll just play under the regular rules. Everybody will play with the same cards. You get 200 if you pass go. There's not any more go to jail cards. We're going to now play for 5 minutes under the regular rules. Well, that is an example of systemic racism. You know what will happen in those last 5 minutes. I'm going to play by the same rules as everybody will play by the same rules, but you'll already know what the disadvantage that you will have based on systemic racism. So just the thought, a real life experience that you may have had to kind of illustrate how systemic racism has worked in our society. I want to give you some examples. So, as a physician, and many of you are providing some sort of healthcare. So I just want to give you some examples of structural racism in healthcare, right? It's part of healthcare. So it's not like anything else. I could give you examples: criminal justice system, housing, jobs. But I'm going to use this because it's what I do. I'm a physician, but it's part of healthcare, right? This is certainly not an all-inclusive list, but here's a list of disparities that we see, areas where there is disparities based on race and racism: access to health care, institutional discrimination. So you think about segregation. These are all things outside of actual medicine, but they affect health and healthcare. Segregation, reduced access to good food and services, the effects of internalized racism, increased exposure to traditional stressors. There's a higher amount of unemployment. Imagine what that stress will do to one's health. Discrimination, the effects of discrimination, not just on jobs and pay, but what are the psychosocial effects, the physiologic effects of discrimination? Again, not an all-inclusive list. I could spend hours talking about each one of these, but just kind of little tidbits for you to think about. If you didn't think that structural racism played a role in healthcare, well, you should by now see with the pandemic has exacerbated, it's exposed and magnified these health disparities in Black and other minority communities. You may not hear about it so much. Interestingly, data has not been well collected on race and ethnicity in terms of the effects of the pandemic, but it's there. So it has exposed and greatly magnified the disparities, certainly in healthcare amongst other things, but COVID has really brought this to light. So it exists in healthcare. Even within the practice of medicine, there's something called race medicine, or race-based medicine, race healthcare, race-based healthcare. Race care is structural racism within healthcare and medicine. Again, not to get too technical, but just to give you an example. When we're practicing, we sometimes have to give medications to people. Sometimes the medications are affected by someone's kidney function. So we will often calculate kidney function, renal function, using something called the glomerular filtration rate. And in the formula, we have them all on our smartphones. You plug in the creatinine, age, body surface area, gender, and race. And interestingly, the race is Black versus others. So you get a correction if you're Black, and everybody else doesn't get a correction. Well, what happens with this correction is when you add the correction in, it actually increases the estimate of renal function. So you put the correction in, your renal function actually looks better than it really probably is. And in fact, than it really is. People will dispute that, but scientifically, there really is no dispute. Well, the way this correction came about, it was based many years ago on the observation that, and this is the observation, that Blacks are more muscular and release more baseline creatinine. So just on some generalization, we have been using this race correction. It's not based on any particular science. You would think that they would measure it in some way. No, it was based on this many decades ago, and this has just been handed down as fact. All right, so what happens when you do this, when you overestimate? I'm going to use an extreme example, kidney transplantation. So if you have renal failure, if you have kidney failure, and let's say it's bad, it's severe renal failure, you're better off if you're able to get a kidney transplant. Right? It's better than dialysis, just generally overall better. Well, here's what happens. We have, these are numbers, it's not important. There's a formula that we use. So if you're Black, if we just put in Black, your glomerular filtration rate is estimated at 30. If you're everybody else, it's estimated at 26. Well, here's what happens. We typically make the recommendation of transplantation with a number of 29. So if you're Black, we put a correction in, you aren't getting recommended for a transplant. If you're white, or really everybody else, you will. This is based purely on an observation and essentially dogma. It's been handed down over the years. That is structural racism within healthcare, within medicine. Imagine the people that don't get that better care. Well, this happens not just, we have it in kidney function, it's also in pulmonary function, in lung function. There's a whole book, there's research that surrounds this, and it was based largely on an observation. Many, many years ago, somebody makes the observation, makes the statement that, well, lung function is different in people who are Black. All right. They assume that there were inherent differences. There's a correction that's put in. The machine, you actually have to turn it. You have to turn it off if you don't want to use it. It's built in. What does that mean? Well, it overestimates function. The care ends up being less. You don't get recommended for certain care until your lung function is actually worse. Right? That's race and structural racism in medicine. Right? There are so many problems that are associated with this. Well, how do you define race? Well, what do you do if somebody is half Black and half white? Do you cut that correction in half? Well, there are no guidelines around it. There's no science around it yet. This is what continues to happen in medicine. And you would think one would just say, well, let's just change that. Let's just get rid of it. It isn't that easy. There's some people that really believe that needs to stay in. Let's just say there's work being done around it. Commonly, these tests, these observations are passed down without really much, if any, scientific backing to it. There's a whole article that just came out in July in the New England Journal of Medicine. So for those of you who are not in medicine, this journal is considered, one of the premier journals in the specialty of medicine. And there is a whole list of calculations that are done using race medicine, corrections that are being called into question. But just an example, again, you know examples from other areas. This is an example in medicine, right? And it's dogma, supposedly science that's just been passed down over the years and accepted as fact. When you use race medicine, and nobody says, let's use race medicine, let's not use race medicine. It's really just more of a common practice. When you use race medicine, what it actually does is it either allows for or it causes the ignorance of social determinants of disease, all right? And it's the social determinants of disease that play the largest role in determining somebody's outcome, in determining health outcomes. So this is what I might do as a physician. I'm going to focus on the person that's in front of me. There's certain characteristics about this person. I'll put in the corrections. When I focus on this, well, it's because the person is Black or Hispanic or Asian that this is happening. Well, I focus on only one piece. What this does is it allows me or it allows me to ignore, or it prevents me from considering what probably amounts to about 80% of what determines the health outcomes of an individual. The physical factors are only about 20% of it, but it's all of these other determinants of health that play a role in the ultimate outcome. And this is where structural racism plays a role. So living conditions, employment, all of these factors that affect health outcome are affected by racism, by structural racism. If we don't think about this in healthcare, we will ignore the largest determinant of somebody's actual health. We're not going to play this here. What I really wanted to do is just get this so that it's in your kind of your handout. This is a great TED Med talk. Dr. Dorothy Roberts is a professor of law and sociology at the University of Pennsylvania. This is one of the best talks probably ever on the topic of race-based medicine. I would highly encourage you to take a look at this. I think it's maybe about 15 minutes, but it goes through everything and more that I just went over. It gives some of her, not only opinions, but some of her life experiences with this. So I very much encourage you to look at this as part of, more education in this area. Okay, so in a nutshell, in 15, 20 minutes or so, we went over racism, structural racism. Again, think of it as an intro to the area with a particular example, me using medicine and how structural racism works in medicine. Okay, so here is, again, another interactive piece. So my question to all of you, and I'm assuming most, if not all of you, you're involved in healthcare. Just by the topic of hepatitis B, you're involved in the care of human beings that are either at risk or have hepatitis B or know somebody that has hepatitis B. What I'd like for you to do is just take a moment to think about this. What have you witnessed in structural racism in healthcare? What are your thoughts? What are your experiences with witnessing structural racism in healthcare? So if you just think about it, just whatever your thoughts are, put them in the chat box. And then, Chioma, this is the part where you'll you'll jump in and help me out with the audience response to this particular question. Okay, good, thanks. And we may spend like 5-ish minutes here. Okay.
Well, I am seeing some comments around people saying that one of the challenges around doing this work within communities is not making sure that we are not reproducing racism in some of these communities. So that's showing up within sort of the service delivery model, and also that's showing up in terms of how we build relationships and partnerships with community.
That's a good thought. You want to do good, and you want to make sure that you don't do bad. You don't want to certainly make things worse.
Some other comments around the way that racism has shown up is the way that we group communities. And so either, in our healthcare system, we have these broad racial categories. And these broad racial categories are not disaggregated in a way in which we're able to see specifically what's happening with ethnic-based communities, which will allow us to have more targeted hepatitis B prevention and treatment and outreach services.
That's great. That's a great observation. This is what we do. You saw from Dr. Bruno's video. We group people. It's what we do as human beings, and it's very important to make sure we look at each person as an individual. Not everybody does everything in a category of a group. So very important to look at the individual.
Yeah, I think another great comment to bring up is the way in which we stereotype communities. And so there's two comments that I think highlight that. One is, the way that we say, and we see this in COVID-19, under the COVID-19 narrative, that we say, Black and Latinos make poor health decisions, causing their own health outcomes, right? So I remember that narrative being around comorbidities, right? And that certain populations have higher comorbidities than others, and that causes, and putting it on the individual instead of the environment. So the individual is causing their own health outcomes. Another way in which stereotypes that fuel racism show up in service delivery models is an example that was shared around the Aboriginal population, where an ER staff played a game to guess what their blood alcohol level was, a patient's blood alcohol level, right? Because we hear about the challenges around alcoholism in some of our native communities, right? So those are two examples that were shared.
Yeah, those are, again, I can think of hundreds, maybe thousands of structural racism examples that I've witnessed over the years. It's ubiquitous. It's very common, and those are a couple of good examples.
And then the other one is the way in which our systems are set up to target certain populations, and then allows it causes those populations to even be more isolated or stigmatized. And so some of the narratives around how there's a failure to routinely provide hepatitis B vaccination for immigrants and refugees might lead to, might be based on the fact of who immigrants and refugees are. And so that was brought up in terms of some of the examples that people are sharing. Mm-hmm.
Great. So yeah, again, there however many people are here is however many examples times 100 maybe. So great. So well, not great, but you've all witnessed structural racism in healthcare or in the care of the people that you're caring for. All right. So here's the next question that I have for you all to think about. What do you think you can do to alleviate structural racism in healthcare? And then again, Chioma, as the chats come in, if you could give us some good examples.
So one response is to call it out when I see it. So being very vocal and present, and acknowledging when it happens as a way to begin dismantling it.
Okay.
Some other examples around if we want to see change around this topic or see ways in which racism is addressed, that we model the behavior, we model what we want to see. So making sure that we are doing our own individual work, so that when we show up in environments, show up within our healthcare system, when we're serving clients, that we are modeling the behavior, the ideas, the thoughts that promote anti-racism work.
Great.
I mean, I think it's great that a lot of people are acknowledging that it starts with the I, and working through the I before you get to sort of collective action and work.
So listen, I'm really glad to hear that you've gotten that response. That will actually lead me into the kind of the tail, or the end of this. So I'm really encouraged when I hear that sort of statement, that it begins with the I, because ultimately, look, there's an I and a we and the they, but hearing that people think about the I think is really a huge key when you think about how we can alleviate structural racism in healthcare. It actually goes to how do we alleviate structural racism and not just in healthcare. What I'm going to do, all right, so great segue into, what can you do? So when I give talks like this, it's commonly aimed at, when we get to what do you do part, it's commonly aimed at the individual who's attending. And I think that's really where it can start. Let me just say, kind of on the outside, looking at actual structures, people need to look at structures, policies, guidelines, procedures, and look to see if there is any structural racism. And when I talk about racism, it's really a lot of isms. Are there structural problems with gender, for instance? So we're focusing on the race, but there are structures that have to be examined and looking at those policies and procedures. But what can you do? What can I do? What can we do as individuals? So I'm going to share this again in a couple slides. There is a book by Daryl Wing Su. He was the person that I quoted for microaggressions. I just took this out directly out of his books. Anti-racism. What can you do to be an anti-racist? It's looking for valid information on race and racism. All right, it's finding that information. You know, when I think about some of the things I've learned recently, I just think not only was I not taught certain things, but I've come to learn that some of the things that need to be taught about race and racism have been actively removed. All right, so we're not getting all of the information that we need. So you've got to look for valid information on race and racism. You need to actively seek out interracial relationships and experiences. So it's one thing to read about or watch videos about. It's another to actually get to know people and their lived experiences. So it's being active about it. You've got to go find out, what is it really like? Not what did I read about, but what is it really like for the people that have these experiences? Right? You need to be open to discussing racial issues. Now, they're easier said than done. This is, as I mentioned, the amygdala hijack. This is a very difficult area to have an open discussion with, especially if you're going to have a discussion with somebody who has been harmed by what's going on. But you need to start thinking about being open to having these discussions and real discussion. That's where the hard part comes in. Expressing positive racial messages to family members, friends, and coworkers. So when you hear a microaggression, are you going to be able to put, kind of a stop to that? Are you going to be able to maybe say something positive rather than agree with might have come out as negative? Standing against racist comments and jokes. So maybe it's a microaggression, maybe it's more of a macroaggression where it's outright something that may be racist. More of them. Again, this is in his book, joining or forming community or professional groups that work on behalf of multiculturalism, diversity, and anti-racism. This means it's going to take some of your time to do this. So it can't just be, yeah, I agree to it, but it's actually spending time. Planning, coordinating, conducting, or attending anti-racism forums with other interested parties. This is a way that you learn more. You learn more and you're being active about trying to solve the problem, to make people more educated. Voting for candidates, all right? So, this is that big area. It's voting for leaders who can actually make a difference, who share your vision of multiculturalism and anti-racism. You're going to be able to do a lot in your daily lives, but you need people, you need key leaders in place that can actually make some of these things happen. Supporting public policies, allowing for equal access and opportunity. So these are lists. Look, we're going to spend only a few minutes. I just threw out a list of items for you. It's not as easy as, okay, let me take these 2 slides, I'll make a card of it, I'll take pictures of it, and then I'll just do these things. These are just ideas. These are some of the principles that go into anti-racist action. And advocating for multicultural curriculum in schools, making sure that the education is there, that it's a full education looking at this as well. All right, those of you who said I, it's looking at the I, yeah, if you're going to be anti-racist, it's introspection. It's examining who you are, why you think the way you think. It's being able to say, I'm going to look at my unconscious biases and I'm going to have a heart-to-heart with myself. Very difficult work to do. We're all busy, get too many things to do. But if you're looking at becoming anti-racist, it really does require self-examination, introspection, self-reflection. All right, so and then on top of that, so for those of you who have been with me now for almost an hour and a half, it's taking the time to learn, right? You must learn. And this is not, I'll read this book and then I'll be good. It's lifelong learning. It's taking the opportunities to learn the history, to learn how to be that person who can open their minds, to learn how to deal with things like microaggressions. None of these are easy, but it's learning. So introspection, learning, then more introspection and self-reflection, and then learning. That's how you become anti-racist. Now, what I wanted to do is share with you, these are 3 of my favorite books, all right, that if when people say, well, what would you read? What would you do? Well, I'm going to give you 3 resources that will help you as you think about this, as you work to become more anti-racist. Daryl Wing Su, he has published so much on the area. I was fortunate enough to have met him, talked with him. We had him give a talk at our institution based around this book. I will tell you, this is one of the best books that I ever read. Don't try to read this all in one sitting. There is a lot of emotion that's involved, but a lot of you might say data, facts that help you when you're trying to come up with the procedure of how you may become anti-racist. Here's a book by Dolly Chu called The Person You Meant to Be. So the way I looked at this, I read the Race Talk book first, heavy reading, but it was life-changing for me. This book talked about, essentially how do you become anti-racist, but don't beat yourself up too much. You're going to screw up. Don't beat yourself up too much. The idea is that you are trying, and that the only way you can ever move forward, the only way we as a society can ever move forward is to try. So this kind of took the edge off of it. And then this is a relatively recent book by Ibram Kendi. So this is often considered to be the Bible. And if anything, here's the title that you're looking for, How to Be an Anti-Racist. One of the best books ever. It's a New York Times bestseller, but clearly one of the best books on the top. May I tell you, read all of them because they have different aspects to anti-racism. So, we covered anti-racism in less than 10 minutes. Clearly, we can't do this all in 10 minutes. But the idea is that it's a lifelong learning process that involves introspection and self-reflection as well as change. All right, so we've spent now, if you count Wednesday, we've spent 2 hours talking about unconscious bias. And what I want to leave you with is unconscious bias. It's part of who we are as human beings. Every one of us has them. I try to pretend that I'm a rational person. I'm not biased. Well, that's just completely wrong. It's part of who we are as being human, and it affects our everyday interactions and decision-making. And it's incredibly important that we work with them. We're not looking to get rid of them. We're looking to work with them. Race and racism, it greatly affects almost everything that happens in life. Certainly in healthcare and health outcomes, it greatly affects healthcare and health outcomes. Anti-racism or anti-bias, if we want to look at a broader picture, is lifelong learning and change. There is all kinds of documentation, bias, prejudice. There is documentation that it clearly creates health disparities and affects differences in care. A publication called Unequal Treatment. I think it's from 2008 by the Institute of Medicine, now known as the National Academy of Science, Engineering, and Medicine. It's documentation. It's all there. So, there was a day when we thought that the best way to treat human beings for illness was to drill holes in their head. So way back when, it was called trepanation or trepanning. What we did was we drilled holes. You're supposed to let out the evil humors, and people got better from it. Well, back in the day, that was accepted medical practice. That was the way we did it, and that's how you got better. Well, clearly over time, we've learned that there are different ways to do things. We don't do this anymore, but over time, we've learned better ways. Well, we can do the same thing with unconscious bias, microaggressions, racism, and structural racism. We can do this. When we go to work every day, all of you who are in this conference, you go to work every day and you are looking to provide the absolute best care for that individual that's in front of you, right? We are looking to do what's on the right. Equity. It's getting what an individual needs to assure that they have the same good outcomes as everybody else. When you wake up for work every day, this is what you do. So it's vitally important that we work on all of those things that we've spent the last 2 hours on. It's vitally important to make sure that we're working on that so that we are truly creating equity for all that we care for. I know that's what you do. This is what I want to do. This is what you want to do. How do we do it best? By working on some of these issues. So I just want to close. It's been great having you as an audience. The interactions that we've had, granted it's been by chat, but I've heard wonderful things that people are thinking about. But I just want to leave you with a couple of quotes. For he who has health has hope, and he who has hope has everything. And then of all forms of inequality, injustice in healthcare is the most shocking and inhumane. So with that, I thank you for your attention. It's been great being able to spend this time with all of you.
Wow, thank you so much, Dr. Lopez and Chioma, for leading us through a self-reflection and a very important conversation for facilitating part of our summit. We are so grateful to have both of you join us, and it definitely helps to reinforce the values that we strive to achieve as a national coalition. We have come to a break in our day today, so please take a minute to stretch, do some more self-reflection, take a bio break, or if you'd like to stay on the screen, if you want to take a minute to fill out the event survey before heading over to the reception, we'd greatly appreciate that as well. So we'll keep on with time. I know we're a little bit over, but we'll take a 15-minute break. I know everyone will need that after sitting for so long. I do. So we'll see you back here at the 2020 awards reception to recognize this year's Hep B champions about 4 p.m. Eastern. Thanks, everyone. Hi, everyone. Welcome to the 2020 Hep B United Awards reception. Welcome back from break. We hope that you enjoyed our first virtual summit. And I have our friend Oliver joining us for the reception this evening. Hey, Oliver. So the Hep B United Awards reception is our annual opportunity to recognize community leaders and organizations who have led successful initiatives to address hepatitis B. This year, we have the pleasure of honoring 9 Hep B community champions and our first federal Hep B champion, all individuals and organizations that exemplify the amazing, small but mighty, and as Thaddeus pointed out yesterday, nimble Hep B community. This year, we're all closing the chapter on a pretty challenging year, and our champions have led us from inside the clinic to out in the community in innovative ways to continue the work, to continue hepatitis B prevention and treatment services. This year's champions include a clinician, leaders of community-based organizations and coalitions, people with lived experiences who have bravely shared stories to reduce stigma, discrimination, and affect policy change, and organizations that have led the way in reducing hepatitis B-related health disparities. So please join me in congratulating, in no particular order, Amy Shen Tang, who's the Director of Immigrant Health at Northeast Medical Services in San Francisco, the Asian Health Coalition, based in Chicago, Illinois, Bright Ansa, one of our Just Be storytellers, Chioma Naji, who you just met, who's the Project Director of the Multicultural AIDS Coalition in Boston, the Coalition Against Hepatitis in People of African Origin, or CHIPO, based in New York City, or of New York City, David Yurick, one of our Just Be storytellers, Pharma Penne, who is a community projects coordinator with the New York City Department of Health and Mental Hygiene, Joe Balistreri, one of our Just Be storytellers that you met yesterday, and last but not least, Richard So, who is the executive director with San Francisco Hep B Free Bay Area. So congratulations to this year's Hep B community champions. And here is a montage of everyone and words of acceptance.
Congratulations to our amazing 2020 Hep B United champions. It is now my pleasure to announce Karina Dan as the recipient of our 2020 Federal Champion Award, given to an individual who has made outstanding contributions to the field of hepatitis B at the federal level. In 2018, we initiated the Congressional Champion Award. Senator Mazie Hirono was given this award in 2018, and Representative Grace Meng was given the award in 2019. This is the first federal champion award that we have given, and we are so pleased that it is going to Karina. We have two very special guests with us who would now like to congratulate Karina on her 2020 Federal Champion Award.
It is such an honor for me to join the Hepatitis B Foundation and Hep B United this afternoon on the occasion of presenting this award to Karina Dan, so richly deserved. I first got to know Karina when she was working at APCHO and was about to make her transition over to HHS. It was just such an exciting time because we were working on a national HIV plan and a national viral hepatitis plan, and it all really blended very well with the forum's program on the national summits on HIV and viral hepatitis testing, prevention, and linkage to care. So we worked with Karina in many different capacities. She worked with us on the planning committees for these meetings, for these summits, as well as representing HHS on the HIV Forum Steering Committee. It was always such a pleasure to work with her, and her current colleagues and peers are extremely lucky to have her join their team. Corinne has always been such a champion for both sound policy based on sound science, and the health of the public, and accepting and really promoting that health is a right that everyone should have access to. So without many more words, I will just congratulate Karina Dan, and thank you again, Hepatitis B Foundation, for putting this event together. And I wish everyone all the very best for the rest of this afternoon. Thank you.
Hello, Karina. It's your old boss and colleague, Dr. Valdesari. I'm here to offer my congratulations for your very well-deserved award as the Federal Hepatitis B Champion this year. Obviously, I wish I could be there in person, but I know that because you're such a strong public health advocate, you understand and appreciate the need for social distancing during our current pandemic. So we'll have to send our congratulations to you electronically. I did want to say on a personal note how pleased I was to hear that you had been given this award. When you first started working with us at the Department of Health and Human Services, I'd heard a lot about your good work at the Chicago Department of Public Health and your work around hepatitis B at APCHO. And frankly, my first reaction was, this person sounds too good to be true. But shortly after hiring you and working with you, I recognized that you were in fact the real deal, and that all of the good things that I had heard about you were in fact very true and right on target. And I have to say personally, since we worked so closely together on the National Viral Hepatitis Act, what was then known as the National Viral Hepatitis Action Plan, it's since morphed into this Viral Hepatitis Strategic Plan. I don't know how many people outside of HHS would understand and recognize how much of your heart and soul you put into that effort. I certainly do, and I want to thank you for that passion and that commitment, and especially thank you for your the importance that you placed on always listening to and seeking out input from individuals and communities who are impacted by hepatitis B and hepatitis C and other adverse impacts on liver health. And so having said all of that, you should really be very proud of this award. You deserve it. You've earned it. All of your friends and colleagues are happy for you and proud of you. And in closing, I just say that I hope that you will continue to bring the same intelligence and commitment and passion in your new job as you did when we worked together at DHHS. So Karina, in closing, I offer my most sincere congratulations on this very well-deserved recognition and award. Thank you. Take care. Give my best to your family.
Hello, everyone. I want to thank the Hep B Foundation for asking me to present this award. I am so honored to be introducing the Hep B United Federal Champion Award for contributions to communities impacted by hepatitis B to my friend and colleague, Karina Dan. I don't know how many of you knew Karina before her HHS role. Karina was a Hepatitis B Policy Fellow at the Association of Asian Pacific Community Health Organizations, or APCHO. And as a policy fellow, she was the first full-time hepatitis B advocate on Capitol Hill. This was a significant responsibility. I was not only confident about her hepatitis B expertise, but I also saw firsthand her commitment to representing and advocating for APCHO and our Asian American and Pacific Islander communities, particularly those who were limited English proficient, those in poverty and without health insurance, and the disproportionately impacted due to hepatitis B. When it was announced that HHS would be including a viral hepatitis policy position and an interagency council, many advocates were quite concerned with who would be selected for this position and if they would be more Hep C or more Hep B focused. What kind of community advocate experience would they have? Will they have clinical experience? What kind of local government versus federal government experience? How can we find the right balance to navigate the politics both inside and outside of government? All good questions. And as an Asian American community advocate and as a representative of NVHR, it was really hard for me to really think about who I should be advocating for. Quite a quandary. Needless to say, when I got a call from Drs. Howard Koh and Ron Valdeseri, the pressure was on to have a recommendation ready. So when I realized that they were calling me to ensure it was okay with APCHO, that they were going to offer the position to Karina Dan, I was so relieved. I completely agreed, and Karina was the right person. So to cut a long story short, obviously, we all know now that she represented us and served us all well. So please join me in sending virtual congratulations to Karina Dan. Thank you, everyone.
I am honored and delighted to receive the Federal Champion Award from the Hepatitis B Foundation. I cannot imagine a stronger partner in the battle to eliminate hepatitis B in the United States than I've enjoyed with the Hepatitis B Foundation. It has been a true pleasure working with your many scientists, staff, and the patients and families you serve for more than 10 years. When I was at HHS, when federal partners needed a place to refer patients, like the young refugees who tested positive as they entered the country, I could rest assured that the Hep B Foundation would assist them to find the care and treatment they need. When we organized World Hepatitis Day events at the White House, the Hep B Foundation was there, often stepping up to present, helping to identify exemplary testing partners, and bringing the patient voices that are so critical to elevate awareness in this fight against the preventable and treatable infectious disease. When the HHS Office of Minority Health announced a grant program, you engaged your Hep B United coalition partners to develop meaningful project proposals. And when we invited programs working toward hepatitis elimination to answer the call of the National Viral Hepatitis Action Plan for coordinated and collaborative elimination programs, you mobilized your networks to join Hepatitis Elimination in Action. Your foundation is strong, unique, and diverse. It includes bench scientists doing funded hepatitis B research with a goal of finding a cure. It includes dedicated public health staff coordinating nationwide capacity building and advocacy. And it includes patients and their families sharing their hashtag #JustBeStories that drive the passion and the mission of your organization. And I would be remiss if I didn't mention your fierce social media presence, which raises awareness and shares informational resources. This award is especially meaningful for me because it will be my last time to be eligible to be considered for it. I've left HHS for a new role at Maximus, leading our group of public health experts to implement evidence-based programs and improve patients' experiences. We'll work in the trenches with agencies at all levels of government to reinvest in and reinvent public health programs to meet the needs of people in these complex times. The partnership I've had the privilege to share with the Hepatitis B Foundation is the model of the strong partnerships I hope to establish in my new role. There's so much to be done, and so much more we can accomplish when the public health community joins together. Once again, thank you for the honor of this recognition, and especially for the more than 10 amazing years. I look forward to learning about your new projects, successes, and opportunities to support the Hep B Foundation in new ways.
Congratulations again, Karina. So well deserved. And we missed you just as much in the hepatitis world. They are so lucky to have you at Maximus. And congratulations again to all of our community champions. You definitely lead the way for all of us, especially this year. Thank you everyone for joining us for a reception. I want to go ahead and close out our summit now and just say a lot of thank yous. So thank you to Sherry and Jeff for your leadership, for leading our coalition since its inception. We appreciate you and you are our wise leaders. So thank you for being mentors for all of us. I want to thank our event sponsors as well for supporting our event and your generosity. Thank you to our planning committee for putting together a wonderful, well and thought out program and helping us to not only discuss important topics that were already on our radar, but also for giving us time for self-reflection over the past 3 days. I also want to thank the staff and a very special thank you again to Beatrice Zovich, who really is the person who ran the show. And she took care of all the details, and you've probably run into her in the chat box and ran into her for help. So Beatrice, you're amazing. Thank you again for putting together this summit and putting together all the details, really stepping in. And to everyone, thank you for being here. We know that you oftentimes get screen fatigued, virtual conference fatigued, especially now that we're at the end of the year. You've probably attended several. So thank you again for being here virtually. We hope that next year we will see you live in person. So fingers crossed. I think there is hope at the end of this tunnel. I just wanted to let everyone know that before we close out, there is also the event survey. We really would appreciate your feedback, especially since the event was virtual this year. We'd like to know your experience, how it went, how your experience on the platform went, what the topics were like. So if you navigate back to the menu, you'll find the event survey there. And then many of you have asked about copies of presentations and the recording. If you'd like to watch like Dr. Lopez's program again, that will be available on this platform from now until a year from now. And we'll also receive our own copy of the recording, and we'll post it on Hep B United's YouTube channel. So you'll be able to access that there. But we'll follow up with an email with everything so that you have it handy. And I know we're closing the program early, and just as if we were together having a drink in DC on the Hill, feel free to stick around and chat with each other. That direct message and video chat features are still there. So feel free to continue chatting in the chat box and mingling. And thank you again. Hope to see everyone in person, like I said, in 2021, fingers crossed. And please stay safe and please stay in good health.